Now, in order to be a functional ACLS provider, one must have the basic knowledge to recognize and treat patients with acute coronary syndromes, otherwise known as ACS. In this section, we'll be learning how to assess and treat the ACS patient following the latest recommendations and guidelines. Now, an initial 12-lead ECG is used as part of the identification process for all ACS cases. The three ECG categories for ACS include ST segment elevation, which suggests an acute myocardial infarction or AMI, ST segment depression suggesting ischemia, and non-diagnostic or a normal ECG. STEMI is going to be the focus of this section as it's the most time sensitive for reperfusion therapies and can limit the amount and extent of the myocardial damage. Now, although 12-lead ECG interpretation is beyond the scope of the ACLS provider course, some practitioners who are ACLS certified will have already been trained in the interpretation and reading of 12 leads. For these particular individuals, this ACS case summarizes identification and treatment of STEMI patients. Remember, the main goal of a STEMI ACS, STEMI meaning ST elevation myocardial infarction, is to reperfuse myocardial tissue that's being damaged by blockage. Reperfusion may involve the use of coronary angiography with balloon, angioplasty, and stenting, otherwise known as PCI. When PCI is used as the initial reperfusion treatment for STEMI, it's referred to as primary PCI. Treatments other than primary PCI include, but aren't limited to, oxygen, aspirin, nitroglycerin, both sublingual tablet or spray, fibrinolytic therapies, and heparin, both UFH, which is unfractionated, or LWMH, meaning low molecular weight heparin.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Welcome. My name is Nikolaos Nikolaou. I'm a cardiologist involved in cardiac intensive care, and I'm speaking on behalf of the writing group of the ERC Guidelines chapter on the initial management of acute coronary syndromes. In the next couple of minutes, I would like to point out why the ERC ACS chapter is of additional value to other existing guidelines in the field, such as those of the European Society of Cardiology or the American Heart Association. The first thing that makes these guidelines distinct is that the main focus is put on the pre-hospital decisions and management of ACS. We all know that most of deaths due to an ACS occur suddenly before patients reach hospital, so we can only prevent these deaths by making a prompt on-site diagnosis and treating patients effectively. Therefore, it was very important for the ACS writing group to focus on the needs of those healthcare providers who will be the first to contact and manage patients with ACS. We also felt that it is important to concentrate on questions that will help in decisions of regional systems of care. We tried hard to present the appropriate treatment interventions for patients with STEMI according to the site of patient presentation, pre-hospital, emergency department, local hospital, or even specialty center. Also, many of the topics covered were intentionally focused to answer questions based upon different community resources. And last but not least, the ACS chapter, like all other ERC guidelines, is based on science reviews that are produced collectively by experts all over the world working under the umbrella of the International Liaison Committee on Cardiopulmonary Resuscitation. This time, the reviewed questions have been tackled using a series of systematic reviews and meta-analysis, with explicit judgments about the strengths and weaknesses of the evidence base made according to the GRADE methodology. We do recommend that the ERC ACS chapter is studied in conjunction with the ILCOR ACS co-star document, which is published simultaneously in the same guidelines volume. So go ahead and read these documents in detail.